to remind you all to use the chat function judicially, just to allow us all to be fully present in the room while Justine and Mary are speaking to us. But do please pop your questions as you think of them into the Slido, so that we can take them at the end, or indeed save them up and ask them in person. That would be very welcome as well. A quick note on self-care. Some of the issues that we will be covering today are sensitive, and some of you might find them difficult to listen to or triggering. So just a note, and we always say that at community of practice meetings, to look after yourself. If you need to step away, access relevant support, especially if you're finding what you hear distressing, speak to somebody, especially you know, the support functions within your own organizations. We also want to encourage you to share what you've learned today with your colleagues. Invite them along to future community of practice meetings. Ask them to join the mailing list. Our email address is here. But please do not share any identifying details of the people who have shared anything, if there are people who share anything personal. And as with any of the community of practice meetings, there's never an expectation of anybody to share their own story or their own experience. So just to put that out there. This session is part of a series of sessions that we organize for the community of practice to address racialized health inequalities through using an anti-racism approach. And we are a really informal community of people who are just committed to building our understanding and our skills to better address and more effectively address racialized healthcare inequalities through an anti-racism approach. And we are all learning. So this is a learning community. And today I think we have a lot to learn. So at this point, I'm so delighted to welcome first Justine, and Justine is going to say a few words to us before introducing Mary. So Justine Craig is our Scottish Government Chief Midwifery Officer, and so happy that we have you both here today, Justine and Mary. So handing over to Justine.
Thank you very much indeed, Andrea. What a great introduction to the session, I have to say, and really makes us all quite mindful. So I'm Justine Craig. I'm a Chief Midwifery Officer in Scottish Government, and it's really good to be here today for this incredibly important community of practice session, improving maternity care for global majority women. Excuse me. Many of you will be familiar with some of the publications in Scotland and further afield around Black, Asian and mixed ethnicity women's experiences of our maternity care. One being the AMA publication on birth outcomes and experiences report in 2024, and the 5 times more experiences of maternity care in 2022. So AMA's report highlighted a number of key areas for improvement and acknowledged the importance of us working together in partnership, both locally at a national level, to amplify the voices of women from marginalised and racialised communities and really improve their experience and their care. You will also be very aware of the Embrace UK data brief published in October 2024, which highlights that disparities in maternal mortality and morbidity remain, despite all the information we have around this, as well as the Embrace UK report, which was published just December there, which highlighted the importance of access to interpreting services for women and families and the importance of equity of access to our maternity care. In addition to this, the Embrace UK report in the perinatal mortality reports published in 2024 highlighted the compounding impacts of socio-economic deprivation for babies of Asian and Black ethnicity in particular. So each NHS board has access to all the Embrace data, along with the data that's produced by Public Health Scotland by ethnicity, which helps to provide us a baseline against which to measure their improvement and the impact that they're making. I think it's really clear that not only the outcomes are worse for these women, so the higher maternal mortality and morbidity and infant morbidity and mortality, but their experiences of our services are also worse So they have less informed choice, less partnership, higher rates of interventions, and not being treated with dignity and respect and compassion. And every woman receiving maternity care in Scotland is entitled to this care. It's a minimum entitlement. And every single woman should be receiving individualised care supporting their own unique circumstances. In September 2024, the Cabinet Secretary for Health and Social Care issued a statement that recognised racism as a significant public health challenge, and I think we can very much see that that is the case. He asked all NHS boards to develop anti-racism plans, which included specifically perinatal care as an area of focus. Scottish Government supported a short life working group for racialised inequalities in maternity care to be set up, and this group has now concluded. It was a group that used a co-production model to develop agreed recommendations, and the co-chairs were Marie Adams, the Chief Executive of AMA Birth Companions, and Dr. Alistair Campbell, the RCOG Scotland lead and consultant obstetrician. So the group have developed a package of work to take forward across the year, and this package and recommendations have been driven by feedback and expertise of the group membership, which included service users and subject experts. And the focus has been on deliverables, which is great, including short, medium, and long-term priorities, and a work plan for action with targets for delivery. So the document was published last Thursday, and it was published to boards under a director's letter, and it includes an action plan, interpreter's toolkit, and evidence. So moving on to what we want to hear, in Scotland in 2023, just under 15% of women accessing our maternity services are recorded as being from an ethnic minority group. And NHS Greater Glasgow and Clyde has the most diverse population in Scotland, followed by Edinburgh and Aberdeen. So it's great that GGC is working so closely with AMA Birth Companions to better understand the needs of women and families, who they serve, and how their services can better meet those needs in an equitable way. So I'm really, really delighted to hand over to the GGC Director of Midwifery, Dr. Mary Ross-Davey, who's been instrumental in developing the relationship with AMA and is here with us today to talk to us about the work that's been happening within the board. And the work that Mary and her team have been doing is both so enlightening and thought-provoking. So I'm really pleased to pass over to her now so she could share with us how we can be better, how we can do better to improve the experience and outcomes of global majority women accessing our services in Scotland. So I'll hand over to Mary.
Thanks, Justine. What a fantastic introduction. Really get great scene setting, I think, for the rest of the session, and certainly I don't intend to be speaking at people for the next hour and 20 minutes, so I'm really keen that we do get to the point where we'll have some really lively discussion, and I know that there are colleagues on the call who've also been doing work in this area, and I think it will be really great to hear from them as well. So I'm certainly not wanting to imply that there's only good work in this area going on in Greater Glasgow and Clyde. So my name's Mary Ross-Davey, and I'm Director of Midwifery for NHS Greater Glasgow and Clyde. I came into post in June 2022, so just over 2.5 years ago. And I was really keen as soon as I came in to post to begin to focus on this work and see what we could do together to improve. So really today, I just want to share some of that work that we've been doing, and it's very much been a team effort across multidisciplinary and multi-agency team in GGC, and just wanted to share that with this wider community of practice. And I'm really grateful to have been asked to do this. Really happy to share our experiences so far. It's early in the journey. It's certainly not a finished piece of work that's tied up with a bow, but certainly very keen to share with you the insights that we've had so far. In terms of the language that I'll be using today in the presentation, we in GGC have decided to use the term global majority when we're talking about Black, Asian and other ethnic minority women. We base that partly on colleagues down south who'd begun to use that terminology from the Royal College of Midwives and Royal College of Obstetricians and Gynecologists. We also use the term women, and I'll use the term women throughout. We are aware that some maternity service users don't identify as women, and we would always personalise our language to care for those people based on their preferences. What we've decided to do in GGC is that we use what's called a partial additive approach. So we generally use the word women, and then on occasion through any document or report or presentation, we will also use gender non-specific terms like pregnant or birthing person. So it was just to make clear if you're finding yourself, questioning the language that I'm using, just to explain the decisions that we've made locally around that. Certainly the work of NHS GGC in terms of anti-racism didn't start 2.5 years ago. There's been very long-term work that's been undertaken in the board, looking at the intersectionality between race, poverty and disability. It's really building on 30 years of history in that field. We've also got all of the national context, and Justine's touched on some of that in terms of Scottish Government guidance on anti-racism plans. And we, in the corporate management team, so beyond maternity, have set out very clear priorities in this area. We've also had representatives from GGC on the National Short Life Working Group that Justine mentioned. So we're very much trying to do this in collaboration with wider networks and groups. I just wanted, because I was aware that on this call there's going to be some people who aren't as familiar with maternity services and others. So those of you from maternity services can just switch off for a bit here. But I just wanted to explain about what maternity services in GGC do. So we provide care for women antenatally, intrapartum and postnatally, around 13,000 women a year. So it's about a quarter of the births in Scotland. And we do that in a range of different settings. So we provide intrapartum care mainly in our 3 large maternity units. So that's at the Royal Alexandra Hospital in Paisley, Queen Elizabeth University Hospital in the south of the city, and the Princess Royal Maternity in the north of the city. We also have 2 smaller rural community midwifery units, one at the Vale of Leven and one at Inverclyde Royal Hospital. And each of those just provide a small number of births a year. But all women across GGC receive universal maternity care from midwives, and that's provided out in community settings, so through our community maternity units, GP surgeries, women's homes, as well as in outpatient departments in our hospital settings. So all women will receive around 8 to 10 antenatal appointments from midwives during their pregnancy. And some women will then also require additional care from other members of the multidisciplinary maternity team. So that includes obstetricians, dietitians, anaesthetists, perinatal mental health team, social workers through their journey. So most women give birth in a hospital setting, but we do also provide a home birth team. Women generally stay in hospital for 1 to 2 days after the birth. And then when they go home, they're visited again by their community midwifery team for around 10 days after the birth before we hand over to the health visiting team. What we've been building over the last 2.5 years in GGC is much more continuity of care into our system, so that women have a named midwife from the beginning of their pregnancy who should provide the majority of that care then through that universal pathway of 8 to 10 appointments, and then for those home visits after the birth. And that really helps in terms of a whole range of experience and outcomes, particularly for women living with deprivation or facing health inequalities. So that's an element of the care that I won't particularly focus on today, but is an important background.
Mary?
Also, yes.
Sorry to interrupt. Would you be able to put the slides on like slideshow, just so that they're
Yes.
a little bit bigger for people on small screens?
Absolutely.
Thank you so much.
I was nervous about doing that because sometimes when I've done that, they've not moved on. But are they moving on?
They are moving on just great.
How
Thank
lovely.
you.
That's great.
Sorry.
Good. No, thanks for mentioning it. That's great. So Justine mentioned in her introduction about the importance of the Embrace report. So these are UK very well researched, very well respected reports that have been going on for around 70 years, actually, where they look every 3 years at maternal mortality. So that's women that die during their pregnancy or in that year after the birth. And then they've also then developed reports looking at perinatal mortality. So that's looking at stillbirths and neonatal deaths as well. So the graph on the right shows you the overall figures from the last Embrace report, showing the rate of maternal mortality. So that's women that die, which is thankfully a very low number in the UK. 9.7 white women per 100,000 women die during the maternity journey. But you'll see those figures are much higher for Asian women at 17.6 per 100,000, and then for Black women, 37.2 per 100,000 maternities. So really a very stark contrast and disparity between those outcomes. And then this graph here is about stillbirths, and you'll see from over the years that there's always been this real differential between stillbirths, between white women, which is the lowest line there, Asian women in the middle, and then Black women at the top, Black babies, so much higher rates of stillbirth. I think what's always really important whenever I've been involved in trying to create any positive change in services is it's really important that the local staff feel that what you're doing relates to their population that they serve. And quite often, just reading a UK report can feel quite distanced from the experiences of people, for example, in Glasgow. So we felt it was really important to look at our local NHS GGC statistics and to really understand whether they were similar to the wider UK Embrace statistics. So that was really one of our starting points. There had also been work underway in 2022 seeking to hear directly the voices of women from global majority women who had been through maternity care. And our equalities team had set up with AMA Birth Companions a number of focus groups, and you'll hear some of those stories in some of the next slides. The picture on the right actually is a fantastic mural that we had on the side of the Princess Royal Maternity Hospital, still there. And it's one of the women that we've cared for over the last 5 years, who was also supported by AMA Birth Companions. So that's been a really lovely outward visible sign of what we're wanting to focus on and improve. And then from the Best Start review. So this, hopefully most of you will have heard of the Best Start recommendations. This was a Scottish Government programme for maternity and neonatal services that was published in 2017. But then when it was refreshed after the pandemic in 2022, there was a renewed focus on improving care for global majority women within those recommendations. So we were keen to make sure that we were addressing that new refreshed focus. We were responding to local statistics, what we'd heard from local women, and that we were also then really engaging in the equality outcomes that had been set in GGC. And that until that point, maternity services hadn't been very well engaged in seeking to implement some of those equality outcomes. It had sat very much to one side in terms of the equality and public health teams. So it was an important element to bring frontline maternity staff into this work. So just looking at our GGC population, and you'll have heard from Justine there that nationally in Scotland, it's around 15% of women are of global majority in Scotland, but you'll see the figures for us in GGC are quite significantly different. So PRM is the Princess Royal, so that's the north of the city, where 28.6% of the women that we care for are from the global majority. QEUH, south of the city, 33.5% of the women that we care for are global majority women. And then you'll see in Clyde, which is the more rural end of our patch, you'll see that the rates are somewhat lower at 13.3%, 9.3%, and then 3.8% in the Vale of Leven, which is Alexandria. So we'd made sure that we understood our population in that way by looking at those statistics. The next thing that we wanted to look at is whether our stillbirth rates reflected those disparities that are in the Embrace report. And so what we did is look back at all of our stillbirths in GGC across 3 years, so 2021, 22 and 23. So overall, our stillbirth rate in GGC was 4.65 per 1,000 births. And you'll see that for white women in our care, their rate was somewhat lower than that average. For Asian women, it was somewhat higher at 5. And for African women in our care, it was very significantly higher at 8 per 1,000 births. So that was a really important moment for us as a team to understand that this isn't something that just happens elsewhere. This is happening in our city, in our service right now. And so that gave us a real focus for looking at how can we address this? What are the causes of this? And to really try and dig deeper into different elements of care rather than just looking at that rather stark outcome. So one of the things that we then did with those data when we were looking back at those stillbirths is to do a thematic analysis of all of those stillbirths to understand what were the key elements that were present in all of the stillbirths over those 3 years. And it may sound strange to you, but we hadn't looked at things with that lens before. And I think that was a really important start for us in beginning to look at all of our data and also always looking through that lens of the global majority women that we were caring for. And when we began to look through that lens, it really was very stark what we found. So that the most common theme among those stillbirths is that the mother was from a global majority. So that theme came up, as you'll see there, nearly 35 times. And then some women obviously had several of these themes going on for them. So that real, as we talked about before, those different elements of adversity that women may experience. So the next column down is fetal abnormalities. The next column down is delays with care for reduced fetal movements. The next column is concealed pregnancy or late booking in pregnancy. The next one is interpreter required. The next one is SNPs, which is our special needs in pregnancy team, which we now call Blossom. So those are women generally living with very significant deprivation and social complexity, including substance misusing women. Then twin pregnancy, medical complexity, including COVID, because this covered the COVID period, and diabetes. So that very much focused everyone's minds, I think, just seeing how frequently that was a theme. Because often in maternity services and in a lot of acute services, what we will focus on is some of the kind of simple outcomes or elements that we'll have seen, like reduced fetal movements, or was the fetal heart rate monitoring not appropriately interpreted during labour. But you'll see that element there, so that's CTG, continuous fetal monitoring, is very low down, really. It's quite a rare occurrence for us. So that certainly helped us all as a team, both midwives, obstetricians, and then also the equalities team, looking at this is certainly an area of concern that we need to understand more. As I mentioned earlier, there'd also been some work talking directly with women about their experiences of care. And during 2022, there were 8 focus groups and women were supported by support workers from either Birth Companions, British Red Cross or Roma workers. There was some really very hard-hitting stories that came through those focus groups. So you'll see there when we were alone without the birthing partners, so that's Birth Companions, they do not listen to us. So when they say they, that's the maternity staff. They do not believe the pain we were going through and did not provide any pain relief unless the support workers intervene and ask on our behalf. That was really hard to hear, but it very much reflects what particularly Black women have described in wider UK reports, that there's an assumption sometimes from maternity staff that Black women don't need as much pain relief and don't feel as much pain. And that's often something that has come through those reports. So to see that for our own service was really shocking. Doctors were visiting, they were good, but midwife's behaviour was racist and not friendly. Voice and tone was very racist and unfriendly. NHS staff should understand different communities and cultures instead of making assumptions. Midwives don't check if the patient can read and write English or their own language. Information is often handed over without checking if they'll be able to read the material. So some really hard-hitting findings for us. I'm just aware that I can hear some kind of sound like people are putting something in the chat, but I actually can't see anyone now. I'm just talking to a screen. So if anyone is asking a question or wanting clarity, I'm really happy for you to just chime in and ask me, or for Andrea to just ask me a question as we go along. That's absolutely fine. It won't put me off my stroke. So once we knew that this was the experience of some women, we were clearly very focused on wanting to do work in this area. One of the key changes that we were making since 2022 as part of our refresh of Best Start was to address the Best Start recommendation that all women should have access to all 4 places of birth in any area. And what's meant by that is that women should have access to home birth setting, a freestanding midwife unit, so that's one of our more rural community maternity units, an alongside midwife unit, as well as an obstetric labour suite. We didn't have at that time in 2022 an alongside midwife unit within the Glasgow city area. We had one in Clyde, but it did mean that women in the city of Glasgow didn't have that as an option. So we set about that as a priority and set up 2 new alongside midwife units in the early part of 2023, one in the Princess Royal and one in the Queen Elizabeth University Hospital. The advantage of a midwife-led alongside unit is that women can access water birth, they can access labouring in water, and you'll see there various bits of equipment that enable women to be really upright and active during labour. In a midwife-led unit, you don't have access in those rooms to an epidural, but there's aromatherapy, there's different lighting, there's access to music, massage, and so it really supports women to have a physiological labour and birth experience. And what we know from a host of research is that women who are able to access alongside midwife unit care, if they meet the criteria for that care, they have better outcomes. And that includes experience. So they say they've had a better labour experience, but it also includes a range of outcomes. They're less likely, for example, to have an emergency cesarean birth. So when we started this work, we set up the alongside midwife unit. We did publicity with women, we did antenatal education, we did training for midwives around how to care for women in this setting, because some midwives have lost confidence, particularly during the very medicalised period of COVID, in providing this kind of care. So we did all of those things, and we proudly set up our AMUs in both of the units. And then we thought, well, it's important to have a look at who is actually getting access to this lovely care, the twinkly lights, the aromatherapy, and the great support from the midwives. And so we looked then, one of our project midwives, with the help of the equalities team, began to look at whether global majority women were accessing the AMUs, the alongside midwife units. And so the graphs that you'll see here are the percentage of women from the global majority who were accessing the AMU, the alongside midwife unit. So that was just 32.5%. And the percentage of white women who were accessing the AMU, and that was 51% of women. And these are all women who are suitable for midwife-led care. So they're quite low risk. They're suitable for intermittent fetal monitoring rather than continuous monitoring. So that was a very significant difference. And clearly we were seeing that global majority women who are suitable for this kind of care just weren't getting through the doors. So we then also looked at the figures for the Queen Elizabeth Unit Hospital, and actually very similar in that there were a lower number of global majority women that were getting access to that low risk intrapartum care. So what does that matter? The way that it matters is that if women aren't getting access to that AMU care, then they're more likely to have a range of medical interventions. So what you'll see here is the light blue column is for white UK women in our care. And then the dark blue column is global majority women. And so what we were seeing then is that global majority women were actually having more medical interventions, even if there was no indication for them to have them. Obviously, we want women to have medical interventions if they need them, but we don't want to see women having interventions that can then lead to other interventions. We call that the cascade of intervention. So you'll see here that 25% of global majority women were having continuous monitoring of the fetal heart, and that has a number of implications to have continuous monitoring rather than intermittent monitoring. It can limit your mobility. You're more likely to have to lie quite still on a bed. And we know that women who have continuous fetal monitoring during labour are then more likely to have other interventions, for example, forceps and Von-Tu's births. The next column is fetal scalp electrodes. So again, global majority women more likely to experience that intervention, slightly less likely to have artificial rupture of their membranes, but much, much more likely to have a synthetic hormone drip that's called syntocinon. So 21% of those women had that intervention compared to 7% of white women. So it's clearly really big disparities in the experiences of care that women were having. So the project midwife who had undertaken the audit then decided to run a series of workshops with midwives to help them understand how you could risk assess women appropriately to make sure that global majority women were getting access to alongside midwife unit care when they were suitable for that care. So the way that she did that was that she looked at the records of a number of different women who hadn't made it through those doors and looked at how they had been risk assessed and realised that a number of women were being risk assessed as being high risk and not suitable for that kind of care unnecessarily. And so she then created case studies. I think a lot of us really quite like a case study, don't we? We like a story that we can understand and then think, well, how would I apply that in a particular case going forward? So she ran the workshops, and I won't go into these, they're full of dreadful maternity acronyms, but basically presented these, got discussion going with midwives at workshops about how to risk assess women. And whether looking at those case studies, they would say, yeah, they're suitable for that kind of care or not. And so all of that led us to understand much more about why women were being labelled as being high risk. So one of the reasons is that some women who have moved to Glasgow, it may be through a dispersal programme, they're refugee or asylum seeking women. If they came to Glasgow after 22 weeks of pregnancy, we would immediately count them as being a late booker, even though they may have had very good antenatal care elsewhere. And if you're counted as a late booker in pregnancy, then you're immediately put into a higher risk category. So that was really good for us to understand, because then we could say, right, that's not the definition of a late booker. And so we could revise that guideline for people so that they would take into account if women had had antenatal care elsewhere, so they weren't immediately pigeonholed into the wrong category. Similarly, what we were finding is that some women were being categorized as high risk because they'd had a previous complexity in pregnancy. So maybe a baby that was small or a baby that was particularly large, but actually this pregnancy all was well, but they were still being put in a high risk category because of a previous pregnancy. We also found that women were being automatically put into a high risk category for labour care because they were asylum seeking or because they didn't speak English. And that might be a really important element of pregnancy care, that we recognise that those women may have additional needs during pregnancy. But once they get to a labour care, if they've got the appropriate support there in terms of an interpreter or a birth companion, that actually they shouldn't be at any higher risk physiologically than a woman who wasn't an asylum seeker or didn't speak English. So what you'll see there also is we then had a look at how many women who required an interpreter were actually getting an interpreter. So you'll see there around 30% of the women, a global majority women, required an interpreter, but you'll see that only 1% got an interpreter every appointment. A lot of women had an interpreter at some appointments, but it was a bit hit and miss. And then a significant minority of women had no interpreter at any appointments. And we do know now that the national advice is that you should have an interpreter at appointments. You shouldn't be relying on partners or other family members, children, for example, at antenatal appointments or during other elements of care. So that was really important for us to understand that actually interpreters were being underused for this group of women. And that's really important for a whole range of things in terms of informed decision making and during care. So this was some of the outcomes resulting from the cultural competence education workshops that the project midwife Nicola O'Brien ran during 23 into 24. So you'll see there that the lighter blue line is global majority women, and the darker blue line is white UK women. So you'll see there at the beginning of the journey that white women were much more likely to get through those doors of the alongside midwife unit than global majority women. But as we went through the journey of providing the workshops, so they started in the October of 2023, you'll then see that we did see a real change, and that we were seeing more global majority women were getting through those doors. And you'll see that by the end of those workshops, actually a higher proportion of global majority women were getting appropriate alongside midwife unit care compared to white women. So it showed that that approach had been effective. Obviously, education is not the only piece of work that you need to do, and you need to make sure that you're continuing that work over time. But that was really great for our teams to see and feel that by providing that education, they've made a difference, and for the midwives to feel that actually they were now able to apply that in practice and provide women with that choice of place of care. So we have used this lens now for all of the work that we've been doing in relation to Best Start. One of the elements of the Best Start programme was a key recommendation was that women should have a written co-produced birth plan. So that sets out their preferences for labour and birth care. So that includes things like where they want to give birth, whether they think they want to have an epidural, who they want to have there with them during labour and birth. Really, really important elements of women's experiences of care. So we started tracking how many women in our care had this co-produced birth plan that was then uploaded in the appropriate place on our electronic record. It's very low across the board, very low. You'll see that overall for white women, it was actually less than 20% of women in our care. But for Asian women, it was even lower. It was 10% of women. So that's the top right hand as you're looking at the screen. And then for Black African women, even lower. So as we began to just hold up the mirror again and talk about this to the teams and say it's really important that all women are being involved in co-producing their birth plans. This is where you upload it. This is where it needs to be written by this time. We also implemented a number of really practical things to support the midwives in doing that. So one of the key things actually was that we lengthened the time for antenatal appointments. So we lengthened our booking appointment from 60 minutes to 90 minutes. And we've lengthened our return appointments from 20 minutes to 30 minutes. So that then creates the conditions for the midwives actually to have time and headspace to spend some time talking to women about birth plans and making sure that they're written up in the right place. So I think it's always really important when you're trying to implement a change like this that you just don't just tell staff to do stuff. You say what would help you make this happen. And they were very clear, the midwives were very clear to us that they needed more time and they needed longer appointments. And so when we did that, I think that's been really helpful for them in terms of being able to make this happen. Similarly, we've been tracking continuity of care, another really key element of the Best Start review. And what we wanted to understand was how we could improve continuity of care over time since we introduced a new approach during 2022 and then into 2023. So you'll see that the top line there that is consistently higher than every other ethnic group is white British women who've had higher levels of continuity throughout. But you'll then see, if you get your eye in, I know it's a very busy slide, that actually what we're then beginning to see with some of this work, holding up the mirror, talking about these issues, is that Asian women, you'll begin to see that their orange line has really increased quite significantly over time. And again, then for Black African women, that we've seen an increase in the continuity of care that they're experiencing, and also Arab women. And actually, this only goes up to September 2024, and we've seen a really good increase since then. So I need to update these slides. But I think it's just a really important element that we break down our statistics in this kind of way to really understand more about those women's experiences. And similarly, I think we also need to do this for women from different areas of deprivation as well, and women living in different parts of your patch to see whether there's any inequalities that are emerging. So we've also been doing that, but I'm just sharing with you the breakdown in terms of ethnicity. So this has very, very much been a multidisciplinary piece of work. So I'm up here talking about it, but I really must give credit to our public health and inequalities team who really started this work. And they were very patient with us, I think, in terms of just trying to find a way in to maternity services. And then, but once we did, and we could put that energy together of the maternity team, who we understand how our service works and how we can get access to those data. And then the public health and equalities team with their huge expertise in this area about how to actually focus and improve care. So once we really got together, and by that, what we did was we had a Black, Asian and minority ethnic maternity improvement group that we still have and has been working really frequently. It was chaired by public health, but really good representation from maternity, so from midwifery and obstetric colleagues. And once we've been having that team working approach with a very clear action plan with outcomes that we're working on, and then that has then played into the wider Best Start work, so that our BAME maternity group has then fed in and reported to our Best Start mechanisms. That really means that there's a mechanism right up through the board to look at these kind of outcomes and experiences and look at them in relation to what our hopes are and our aims are for all women in our service, but making sure we're addressing that for global majority women. So really what we've tried to do over the last 2.5 years is create the right conditions for change. So some of that has been really that quite laborious work around getting baseline data. So looking at our processes, our outcomes, women's experiences, and then just being able to hold up the mirror to ourselves internally that this is what was happening. But also what's been a really important element of that is not just holding up a mirror to ourselves, but also having the mirror held up to us by other colleagues, which has on occasion felt really uncomfortable in terms of things like the Amabirth report that Justine mentioned that was published in March 2024, but also having colleagues from outside services, so colleagues from the British Red Cross who run outreach groups with a range of different communities, able to really share with us those experiences. So in order to do that in a really consistent way, rather than an ad hoc way, I've met with the Amabirth companions every other month for the last 2.5 years, but we've also then set that up into a wider third sector network that meets regularly, and we have the teams that are mentioned there on that third sector network, but we also have the National Childbirth Trust, the NCT, we have the Breastfeeding Network, all represented on that group, and those are all of the organisations across GGC that support women during pregnancy that aren't the statutory and health organisations. And that's been really brilliant to build those relationships and listen to them, but also share with them the work that we are doing so that they can share that with their clients and colleagues so that people can feel there is positive change happening. We've also been engaging much more with women than we ever have, really seeking their views on all of their care and a range of different topics. The way that we began to do that, first of all, was through text-based surveys. So that's actually sending women a text on their mobile phones. And we have sent those texts out in our top 10 community languages so that women can reply in their own language. And actually we sent the first text survey we sent out to 12,000 women, and we got 2,800 replies, which I think is pretty unheard of to get that amount of response to a survey. So it definitely feels right to do it by text. You know, this is a young group of women generally that we're looking after. And generally they'll be very au fait with using online surveys and being asked their views about, you know, the gasman that's just been to their house by text. So we felt that was appropriate, and that seemed to prove true. We've also set up a Maternity Voices Partnership, MVP, which used to be called an MSLC. We hadn't had one for many years in GGC. And so we have set that up with the advice and steer of the national work that's been going on in Scotland, which really sets out that MVPs these days have moved and need to move beyond those kind of set piece meetings that happen in a boardroom with some women and some members of the maternity team. And so we've gone much more online for that partnership group. We have representatives from the maternity team, and then we've invited women when we go out to these text-based surveys, would you like to be involved in an MVP? So we've had more than 150 say they'd like to be really involved in an MVP. When we've had our first meeting, we did that on Teams. It worked really well. We have breakout sessions, and we just need to make sure that MVP is really representative. And there's still work to do there, because often it's the case that those lesser heard groups aren't likely to reach out and say they want to be in an MVP or come along to an MVP meeting. So the way that we're doing that is through those partner organisations, so through Amabirth Companions, British Red Cross and others, to go out and use that as a wider reference group for our MVP as well. What the women on the MVP have said is that they'd like to be involved in creating our maternity services, but they'd be particularly keen to be involved in particular streams of work. So some women will be particularly interested in improving bereavement care. Some women will be particularly interested in improving postnatal care and infant feeding support. And so we're responding to that and getting women to come along to things that particularly interest them and that they'd like to help us co-create. The other thing in terms of creating the right conditions is that in order to have a team that is safe with a positive workplace culture, we decided to co-create with all of our staff, so midwives, support workers, obstetricians, everyone else that works in the maternity team, administrative staff, to create a behaviours charter. And this was partly prompted by some of the feedback that we'd had from women, but also from staff about their experiences of working in our service. And the reason that I tell you about this is, so we had a number of online sessions with staff to identify what did they think the top 10 behaviours that they wanted to see in the workplace were going to be. And we gave them a range of about 30 different behaviours that they could then choose from. And what are the top 10 negative behaviours that they did not want to see and that they were going to call out in the workplace if they saw those. And so we did that through a series of online meetings, and then we finished with an online survey with staff. And what was really fantastic to see is that the staff were saying the top 10 negative behaviours you'll see there, hopefully it's a bit small, is they didn't want to see homophobia, and they didn't want to see racism and xenophobia in their workplace, and they didn't want to see sexism, and that they were going to call these things out. So they were the top 3. So it was really fantastic to see that that was coming from the team, that they were wanting to address this and wanting to create that safe culture. So that behaviours charter is displayed everywhere in every clinical area. Every member of the team has been given an individual postcard. And so that hopefully helps people then, if they see any of those negative behaviours, to be able to call it out, because they've got a kind of mechanism to say, this is what we agreed to. And then we are now implementing equality. We have equality and diversity training. Everyone that works in the NHS has had that kind of baseline, but we're now implementing anti-racism training, and we've used the human library approach as well over the last year. Just referring back to those findings that we had around how little we were using interpreting services, when we dug underneath that and we asked staff around that, some of the reason why they weren't using interpreting services is that they weren't sure how to access interpreting services. They were worried about the quality of interpreting that they were getting. There were lots of technical hiccups. There were a lot of glitches in the system. And so sometimes then they just gave up trying. And so what we decided to do there was we did an audit of our interpreting services in maternity care. We asked all of the midwives and obstetricians to feedback any problems that they'd experienced during that month. And then we fed them back to our interpreting service leads so that they understood what some of the challenges were. And some of the challenges were around the quality of the interpreting, and also about the reliability of the interpreting service. And when we redid that audit in March 2024, we found that there were far fewer problems. And so that kind of feedback loop had some benefit in terms of improving the quality of interpreting services. What we actually found out when we started having more of a direct contact with the interpreting services managers is that we're the second biggest user of interpreting services in GGC, behind A&E, ED. So we knew that they would want to hear from us, and we knew that they would want to improve the service they were providing, because this is something that is externally commissioned, and so they need to prove that they're doing it well. So I think that was a good motivator for the interpreting team to seek to improve that service. We then sought to make sure that all staff understood how to book an interpreter. So we've implemented new professional update sessions for all maternity staff. That happens monthly. It's called Tuesday Topics. I'll let you guess what day that happens. And one of the sessions that we did was from the interpreting service, just sharing with them how best to use interpreters to get the maximum benefit, and how to book them, all of those practical things. The pictures here are little tent cards that we've put on every desk in all clinical areas, so people are really aware about how to book an interpreter and when you need to have a face-to-face interpreter. And we're beginning a pilot of video interpreting as well, because we thought possibly that will improve the quality and experience for women of interpreting if they're actually able to see the face of the person rather than just be on a telephone. We've also implemented a GGC-wide, not just in maternity, access to interpreting that women themselves can book directly through an app on their phone. And we're now translating far more of our leaflets and looking at how we can have subtitles and other things on videos that we're creating for antenatal education. The other area that we really began to look at actually was when I arrived in GGC, just by going around and meeting the midwives, I realised that there were very, very few midwives in GGC that were from the global majority. So midwives are band 5 or above. So you'll see there that in terms of midwives, we had less than 4% of our midwives were from the global majority. If they were more senior, band 6, that was 1% of midwives were from the global majority, and band 7, just over 2%. So we clearly were not representing the community that we serve. Is a bit higher among medical staff, so around 12.5%. So we knew that there was particular work that we wanted to do within our midwifery workforce to make sure that we were becoming more representative of the community that we serve. So I was aware that there'd been a lot of work that had gone on in Bradford in particular. It was a long-term project, a wider public health project called Born in Bradford. And they'd done a huge amount of work because in the past, they had very few midwives of Pakistani origin working in their service. And they did a huge amount of work to address that. And they did that through a variety of approaches. But for example, having volunteer roles that were particularly for global majority women in their community, so that those women then gained experience and confidence and then were more likely to apply to become midwives or support workers. They had local Pakistani women on their interview panels for their university programme, a whole range of approaches that they took. So we reached out to Bradford and also Bolton that had done a lot of work on this, so that we weren't just trying to invent a new wheel, that we were learning from areas that had really made progress. And so then that led us to link in with our workforce team and also the University of West of Scotland that feeds us in terms of most of our midwives that come and work with us, to talk with them about how could we encourage more applications from global majority students for midwifery, but also for our support worker roles. And so we now have a regular working group that includes the University of West of Scotland, and we are beginning work with some of our global majority midwives to do outreach to schools, because you don't do what you don't see. So to go out to some of our most diverse schools and talk to them about what a fantastic career and profession midwifery can be. We also are offering work experience and mentorship to global majority school students during this year to offer them some really valuable experience so that they are able then to put that in their personal statements. We're adding in new questions to interviews, and we're seeking to have more diverse panels. We've undertaken a survey recently with staff about their experiences of racism. And we have offered a leadership programme for all of our global majority midwives and mentorship and shadowing with the senior team, so that they can hopefully feel able to step in to more senior roles over time. So I'm nearly there. So what we've needed to do really over the last 2.5 years is acknowledge the challenges that we have, not hide away from those, but then also celebrate successes that we've had along the way, acknowledge that progress that we're making, and really then focus on what we want to do next. So the AMA Birth Companions report came out in March 2024. We were already doing a lot of this work, but that didn't mean that reading that report didn't feel really very difficult. We developed an action plan following that report to address their recommendations. Part of that programme of the action plan after the report was that we've created much more of a formal system for AMA to feed back really regularly to us about really good care that they see and where they've seen less good care. And so that we're able to address that in real time and go back to staff and say, this is what's been seen and experienced. And that's felt really valuable because there's been some really lovely positive stories as well that have come from the AMA Birth Companions that I'm able to then feed back to the midwives. So important that you get that balance, I think. AMA have been to one of our Tuesday topics and provided some insight into what they do, and they're going to continue to provide some further training for our staff about what is the experience of women before they get through our doors of the asylum system, or if they're refugees, because I think there's a real gap in knowledge and understanding for a lot of our staff about what those experiences will have been. We were really delighted that our Best Start Equalities work, some of which I've shared with you, was shortlisted last year for the Scottish Health Awards Midwifery Team of the Year. So that was a really great honour to be on the shortlist for that. And then we've been asked to talk at a range of national conferences like today. And what's great, I think, for the team is that everyone has begun to understand what their role can be in this, and that they are able to then make a difference. Because when you start to break it down, you start to understand it more, and you can start to see what your individual role might be. We've received additional funding from the board, and that's partly because of the AMA Birth Companions report to provide anti-racist training. So I think that does show some of the value in having that external eyes on, in that it helps sometimes to get some of the recognition support that you need. So we're rolling that out for all maternity staff in 2025. We've had support from the Royal College of Midwives UK, and Show Racism the Red Card are going to be one of the partners in providing that training, and it's going to be partially online and partially workshops. And then we're just seeking some additional support for a cultural safety midwife post that will really be able to galvanise this work and how quickly we're able to progress. I'm sorry, that was probably longer than I'd hoped to be talking, but I hope it's been helpful. I'm really happy to answer any questions. Thank you for your time.
Mary, thank you so much. That was just so packed and dense with information, so helpful. As Hilary has already put into the chat, it's so useful beyond maternity services, and we've had quite a few questions come in already. We've tried to transfer them to Slido just because it makes it easier for the team to pick them out. So we'll pick some questions from Slido, but also we want to give people the opportunity to actually make some comments, reflections, and ask questions live as well. So if anybody would like to ask a question live, please do pop your hand up. In the meantime, I'll hand over to Ailey, who will put the first question to you.
Hi, Mary. We've got lots of questions here. Some people were interested in aspects around whether ethnicity beyond just global majority women is considered, and whether you've disaggregated the data and how it's recorded for people who are mixed ethnicity. And there was also a question around whether there's any education going into the women to encourage them to use the midwife-led units rather than the labour wards, whether there was anything within your data that they were asking for those to be put in labour wards, and whether you've considered whether there's any education for those women that's been part of the work that's been done.
Yep. So in terms of ethnicity, we do record if women are of mixed ethnicity or they are of other ethnic groups, other ethnic backgrounds. So I've just not included that in terms of the figures that I've shared with you today, just trying to simplify the data. In terms of asking women about where they'd like to give birth, that's really part of that birth planning conversation that was included there. So making sure that women are being given information about the potential benefits and risks of different choices that they make. And I think what the data has been showing us is that those conversations were happening less frequently with global majority women. And I think that has been partly down to accessing interpreting services, so being able to have really good in-depth conversations. It was partly potentially because people avoided having those conversations because they felt that that was going to make the appointment too long, because as soon as you have an interpreter at an appointment, it takes longer. But now we've given midwives a bit more breathing room with the longer appointments. I think that also helps. But yeah, absolutely. Some women will choose to give birth on a labour ward, even if they're suitable for an alongside midwife unit. And they will say, no, I want everything. I want to have an epidural. I want to have a planned cesarean birth. And that is absolutely available for all women. And it isn't that we are channeling women down one particular path, if that's the kind of question behind the question. I think what I haven't touched on, particularly in this presentation, is that there are risk factors that are more prevalent for some ethnic groups. So, for example, Asian women are more likely to have gestational diabetes, and that brings with it a range of risks for themselves, but also for their babies. And so we need to make sure that we are identifying those women appropriately and really making sure that they get the additional support and observation and assessment that they need, and that they're not wrongly channeled towards low risk care when they should be having that high risk care. So it's complicated in that way, in that you need to do both. I hope that's answered some of that.
I wondered if I could come in just and ask another question, which has come up through the anti-racist work, anti-racist plans that all health boards are doing at the moment. And it was just really a question that's come up for a lot of health boards thinking about the equity focused service delivery. We just wondered whether was it obvious, like, so when you got the data, when you looked at the data, was it obvious from the data what you needed to do to change people's experiences and outcomes? Or if it wasn't obvious what you needed to do, how did you figure that out?
Yeah, I mean, I think that's a really interesting question. I think what you have to do is, what we've sought to do is try and break it down into different elements of care. And so to have a look at, for example, the alongside midwife unit. So what's the experience of that group of women accessing that bit of care? And so similarly, we might then also look at, we now have a specialist gestational diabetic team. So I think that's going to be a really important next step for us to look at. So those women that are coming through our diabetes service, we know there'll be a higher proportion of women who are Asian coming through that service. So let's talk to them about what their experiences have been in accessing that service, in accessing appropriate information. So, for example, for diabetic women, you are needing to give advice about diet. And sometimes that advice around diet can be very much geared to a particular Scottish diet. And actually what you need to do is make sure that you're tailoring your advice then to women and understanding what their diet might look like. And there's been some really great work that's been done in London on that front. So I think there's loads that we can pick up from different areas. So for me, it's been about just trying to look at the different areas and try and understand them from the woman's perspective and also from the staff perspective about what the barriers are, and then try and address them for each little bit, as well as doing that kind of overarching piece around the workforce and what the workforce looks like, but also in terms of what I've recognised is that I had the privilege of having looked after many, many global majority women because I worked in London for the first 10 years of my career. So for me, this was something that I was just much more familiar with, and just recognising where we were starting from in terms of our staff group. So most of our midwives grew up in Glasgow, they trained in Glasgow, they've always worked in Glasgow. And so that we need to recognise where they're starting from in terms of their experiences, and then work with them to help them understand the different communities that we're now serving, which has been really quite a change for many of them from the beginnings of their career or from when they were training. So I think it's kind of starting from where people are as well. And I don't know whether it is always obvious. I think it's often such a mixture of different things about what's happening or what's not happening in a service, and what's happening well and what isn't. So I think there are lots of different things that are going on. And sometimes when we hear from AMA birth companions and they'll tell me about a woman's particular experiences of care, I'll think, God, I think that's probably happening for everyone. So I think that there's lots of things that we need to improve in maternity services as a whole as well, and that's what we're trying to do with these wider pieces of work. I hope that's answering the question. I'm not sure it is.
No, that's brilliant. Thank you very much. It's great.
Thank you, Mary. It's so helpful to have that opportunity to ask questions, and there are still lots of questions. There are two questions which have got a funding element in it, and I'm going to group them both together. So one of them is about increasing the length of booking appointment and birth plan appointment in response to midwife's request. How was this funded? And the other one was about the, so I'm trying to find it now, the MVP, which a positive comment that it has moved beyond the talk shop model, but are you funding this work, and are you making sure staff have got dedicated time to attend it? So how do you support this resource-wise?
Yeah, no, both really interesting questions. So in terms of how we have funded the longer booking appointment and return appointments, is we made the decision that needed to happen to provide high quality care. And then we have then needed to look at, right, so what else needs to change to make that a possibility? So it's still a work in progress. In some patches, we've got the booking appointment just up to 75 minutes because we've just not been able to access the clinical space in GP surgeries. So it's also about that, just trying to find the clinical space for more longer appointments. So one of the things that we've needed to look at is, well, in that case, can we just make sure that we're providing more care in women's homes, because then we're not relying on clinical space in GP surgeries. I think for me, about the length of the appointment, it was something that I'd heard about in my previous role for probably about 20 years, that everyone was saying the booking appointment needed to be longer. And so for me, it was just let's do this and let's see the realities of that. And actually what then happens is that midwives have a bit more time to do their follow-up. It's ring fenced for them, so they can chase up blood results. They can write any letters that they need to after the appointments if the booking hasn't taken the whole hour and a half. And so it actually just makes the whole system more efficient in the end. In terms of the MVP, we haven't bottomed that one out. And I think that's important. I think it's really important that women, when they are volunteering to be part of a group like an MVP, that they are reimbursed for their time. And that has happened down south. And I believe in some areas, and particularly for the chairs of MVPs. And we haven't got that yet in GGC. And that is a gap that we need to work on. In terms of the midwifery staff time, everyone just wants to be involved in the MVP, and so we just do that as part of our roles. For me, it's more important that we reimburse women for their time, because otherwise you do then set up a system where you're just going to have women who can afford to give their time for free to be part of an MVP. So that's one we haven't solved yet.
Thank you so much for your honesty. And I think it's so important to recognize that it's all a journey for everybody and we're all learning, but we can learn so much from each other. And we've got Monica. Monica, thank you for coming in and raising your hand. You're on mute, Monica.
It is really, thank you for letting me speak. You know, I thank Mary with your study and all your report. I myself is a community champion up in the Highland, which are the poor relations to everybody. We hardly manage to get a lot of the time interpreter for GP, not alone midwife, maternity. So, but I think you say that you are giving the midwife extra time. You know, that is very good. But I think in the GP they say whenever I ask, for interpreter for patients, our members, because I'm the chair of the Chinese Association, I used to run my own interpreting company, but because of tendering, I don't have £1 million in my bank, so I become a volunteer for our community and also other ethnic group. So maybe, in the past, actually now we are still, whenever I book an appointment for ethnic minority, they say it has to be a double appointment, and it needs to, they then put you, say, oh, we can't do it this week, we have to do it further another week. So maybe the midwifery need to think not just extra time, it is a double time, because it need extra. When I interpret for a psychiatrist, half an hour appointment become hour and a half, and it is no joke. You need that time, and I applaud your intervention and your passion about improving the service, which because I myself never have to use the maternity because I've never had children, but I act as an interpreter and I know it is so much miss with the service. And then sometimes they say, why are you here? Because the person speak English. They only can speak English as a greeting, as a simple answer questions, but doesn't mean that someone can say hello and I am fine. That means the person can speak English, and that has to be changed. I am not just speaking for the Chinese community, but most ethnic minority find that the NHS has the misconception that you are trying to help, no need because they speak English. And then also, you really like the hear that you use, the phone texting for with the ethnic minority to engage them, because why you get so much reply, because they can type in their language, and that makes a difference. Because if you send them, majority of them don't have internet, or not internet but phone, computer, Wi-Fi. But the phone, they can do it because that is the lifeline. They communicate and they type in China. Well, like as we would type in Chinese, they can translate it straight away into English. Not the best, but at least you can understand what they're trying to tell you. Or if you send them something, they can translate it with their, like WeChat, WhatsApp. They can translate your message in their language. And it is such a fresh approach. And I have been working towards it. And I am so proud that, in Glasgow, you have this system. And then I hope it will, rub off to Thailand. And accidentally, I have been invited by the UHI, the nurse training, to give a talk, on nothing but, nursing staff with the maternity. So I'm so pleased that today you have given me so much hope, and to be able to relate it to our Highland student. And I hope, Mary, you will allow me to tell them a little bit of your success, because I am just someone work as a bridge between community and providers. And maybe you would I may be able to contact you, email you, to get a further insight, and then I can pass it on. Maybe you can pass it on to them yourself. but I have been invited as a speaker for this particular issue. So I'm so pleased, and I'm really so happy to hear something is changing. Thank you very much.
Thank you. It's very kind, and very happy to be contacted. I'll put my email in the chat.
Thank you so very much for coming in, Monica. We've got Michael got your hand up. I'll take Michael, and then I'll take another question from the chat.
Hello, thank you so much, Mary. That was a very good presentation, and hearing some of the work that you're doing with the communities to reach out and engage with the global majority. My question is around how you're going to reach out to more grassroots organizations that might work with the racialized communities, because I think that is also critical. It will give you a wide range of people from different backgrounds and communities. I think that will be a very good opportunity, especially now that you've got this research done and you've got this kind of feedback. I wonder how you, or if you're even thinking of reaching out to other grassroots communities, because what you're doing is very significant, and it will be very helpful if other communities were involved in some of the work that you're doing.
Yeah, absolutely, Michael, and I probably haven't done that justice. That is absolutely part of the work that's being done. We have peer workers that are out being involved in a number of different groups, including things like the African Women's Network that are based in the south side of Glasgow, and other community groups. And so they are regularly going out and having those conversations, and then feeding back. And certainly it's something that we should and can continually build. But it is something that we have, and through people like the British Red Cross volunteers as well. It's been really helpful, as well as AMA Birth Companions.
Thank you so much, Michael. We only have 5 minutes left, so I'll try and put 2 questions together to Mary, and if anybody else wants to come up in person, or Rahima has picked another question out that should be asked, please come in. Hilary asked that she's interested to know what interest there has been in the work from other parts of NHS GGC, how is the learning being applied? And then we've got a question from Isioma, which basically asks, beyond education and engagement, how can an anti-racism and cultural safety lens be applied to clinical governance in NHS GGC? So basically just kind of widening out that approach and learning.
Yeah, it's been really good to have that focus, I think, through the Scottish Government anti-racist plan, and then last week's publication that Justine mentioned. And at the last board meeting where I presented our new maternity and neonatal strategy, which very much builds all of this work as a central part of that strategy, our work in this area had already apparently been mentioned to the board. So that was great. It is being spread right up to board level, and they said that they'd be interested in us coming back to the board to talk about the work that we've been doing. So I think there is that real interest and support that we've had really to keep developing the work, and hopefully that will extend to providing us with a specialist midwives role eventually. And in terms of that, how we've built it into the clinical governance processes, if I just talk from a very kind of practical point of view about what we've done in maternity. So one of the things that I had noticed in complaints is that it seemed to me that there was really quite a high proportion of complaints from women whose names didn't appear to be English. And then when I asked, so we thematically analyse our complaints, when I asked whether we had a category, a theme for discrimination, we didn't have that as a theme. And so you couldn't then gather stats saying, the theme of racism in their care was you know, what the proportion of that was. So we've now added that as one of the themes. So that's kind of practical. Let's make sure that we're really picking up these issues and not just putting it down as poor communication, for example, which is where it probably would have sat before. Similarly, when we look at clinical risk incidents and serious adverse events now, that's something that we now always include. So we say this was a white British woman, or we say from, you know, if she was from an ethnic minority background. And we also talk about whether interpreters were used at every appointment. So we are now including that when we are looking at adverse events. So in terms of our clinical governance processes within maternity. So those are just kind of practical examples of how we are using that within our clinical governance processes. In terms of the wider clinical governance structures, I don't know. I think I'm keeping my lens quite focused on maternity at the moment.
Thank you so much, Mary. We have 1 minute left. I will take 30 seconds of another question, Rahima, if you think you've identified one. Otherwise, I think we would carry on for another hour at least, if anybody wants to raise their hands. Anything from you, Rahima? Might have lost Rahima. Mary, thank you so much for your time, and Justine for being here. This has been absolutely amazing, and we just thank you for your leadership, and really feel so honoured to have the time with you today.
Well, that's incredibly kind. I don't think I deserve all that at all, but I will take that. It's very kind of you, and I really appreciate everyone and your comments and questions. You know, that feels really lively. And I did say that I'd put my name in the chat, so I will do that. And I am really happy to talk and obviously, you know, challenge. And I apologise if I've, you know, not put things in the right way or answered your questions. But really happy to continue the conversation going forward. Thanks so much, everyone, for your time.
Thank you. Thanks so much for coming today and for your time, Mary and Justine and everybody. Bye.
Bye. Thanks a lot. Bye.
Thank you.